non-small cell lung cancer. I'm a medical oncologist from the Peter MacCallum Cancer Centre. This is the outline of my talk, so I'm going to talk about demographics and prognosis, as well as the staging and treatment of early stage disease, the use of adjuvant chemotherapy, the treatment of advanced disease, and touch upon the use of some of the novel agents that have now made their way into the clinic. So lung cancer is in fact the most common cancer worldwide. It's both the most frequent, with 1.8 million new cases each year, as well as unfortunately the most deadly. In Australia we have about 10,000 cases per year and unfortunately many deaths, and overall lung cancer actually accounts for 1/5 of all cancer-related deaths in Australia. This slide shows you the most common cancers in Victoria, with on the left side the incidence and the right the mortality. And you'll see that although lung cancer is not the most common in terms of incidence, it does top the mortality table, because many of the other more common cancers are actually relatively easily treated these days. There is some room for hope though. This slide shows you the trends in incidence and mortality over the time with Cancer Council figures, and you'll see specifically for males that both the incidence and the mortality is trending down nicely. However, in females, we're really yet to see the peak of lung cancer, and this is thought to be because of a later uptake of smoking by females. In terms of risk factors for lung cancer, smoking is the main risk factor, as you would know, and the history of smoking is present in 90% of cases. However, increasingly in the clinic we see patients who've actually stopped smoking and don't think of themselves as smokers anymore, who may have stopped for many years or decades. And the risk of getting lung cancer certainly markedly declines after cessation, but never completely returns to baseline. There are some important other risk factors that are recognised, and this includes exposure to passive smoke as well as indoor cooking fumes. Increasingly also radiation in cancer survivors from other cancer types such as breast cancer or Hodgkin's lymphoma who have received radiation treatment to the chest. And there's also increased risk with exposure to other chemicals including asbestos, marijuana, various heavy metals and radon. This slide shows you the risk of getting lung cancer based on when someone stopped smoking, and you'll see at the top continuing smokers who have a cumulative risk getting above 15%, but depending on how early someone stopped smoking, the closer the risk of getting lung cancer returns to baseline. And particularly for those who are able to stop smoking before the age of 30 or 40, the risk is pretty similar to a non-smoker. How about screening for lung cancer? So there have been a number of studies in this area, and certainly prior studies that used screening chest X-ray have not been able to demonstrate a decrease in lung cancer mortality. There was an influential publication a couple of years ago of the National Lung Cancer Screening Trial, and this was a trial that took current and former heavy smokers who had a minimum of a 30-pack year history and were aged between 55 and 74, and randomised them to have either a yearly chest X-ray or else a yearly low-dose helical CT scan over a 3-year period, and then they were followed. And they're actually able to demonstrate in this study a 20% reduction in lung cancer mortality in those who had the low-dose CT scans. And you can see the numbers there of deaths from lung cancer. But the problem with this study is that they found lots of other stuff. So on average, about 1/4 of the CT scans were abnormal, but many of these were actually false positives with various other abnormalities that you might find in the lung of a smoker, with a false positive rate of 96%. And really there's been questions about the cost effectiveness of this approach because of the many procedures that had to happen to work out if all these abnormalities were cancer or not. So although it's now recommended in other countries like the US, this practice is not currently recommended in Australia, and importantly should not be considered a substitute for stopping smoking. So how does lung cancer present? So increasingly these days it may be incidentally detected. GPs doing a lot more imaging than they used to, and so around 10% of cases it's incidentally found when someone has a scan for another reason. However, for the majority of patients they will be symptomatic, but often have the type of symptoms that we do see in people who've been smokers who've got chronic airways disease. So that sometimes confuses the presentation, but it's really an exacerbation of pre-existing symptoms that should raise concern. So typical symptoms may include cough and an increase in sputum production as well as breathlessness. There may also be systemic symptoms such as loss of weight and fatigue and people going off their food. And then less commonly, there'll be more kind of lung cancer specific symptoms that you'd be very concerned about, such as development of a hoarse voice from a recurrent laryngeal nerve involvement, or development of hemoptysis or a pleural effusion. People also may present with specific syndromes that are unique to lung cancer generally, such as the development of SVC obstruction or a Pancoast syndrome. So there's a range of different symptomatic presentations that may occur. This is a picture of a patient from the Peter Mac who had, as you can see, very dramatic SVC obstruction. So you can see the plethora in her face, as well as the dilated chest wall veins and actually significant edema involving not only her neck but also her arms. Clubbing you would be well aware of, and you know it's very important when you're doing a short case to make sure that you look at the nails in case that's the sign that they're trying to get you to detect. And apical tumours of the lung, as you can see here, can cause the Pancoast syndrome, which you'd also be aware of, with meiosis, ptosis, and a lot of loss of sweating on the affected side. In terms of metastatic disease, where does lung cancer like to go? So the common sites are brain, bone, adrenal glands, and liver. It can obviously go to other places, but they're the most common sites. So how do we work up a patient with lung cancer if we find something like this abnormality on the CT scan? How are we going to work that up? So the aim of the investigation is to get a tissue diagnosis, but also to stage the patient, as this is very key in determining the prognosis and the treatment plan. So in terms of diagnostic procedures, what we need to get is tissue. It's possible that we may be able to get that from sputum cytology, but we know that the yield from that is relatively low. It is increased by getting a series of 3 sputum samples, but that will only give us cytology, and increasingly these days we want to get histology to allow molecular testing to occur. So we may be able to get that by CT guided biopsy, as you can see here, but increasingly more and more our respiratory physicians and thoracic surgeons are able to use bronchoscopy with the associated ultrasound either via EUS or EBUS to get us very good biopsies both of the lung as well as of the nodal disease in the chest. And occasionally we have to do a more invasive surgical procedure such as a mediastinoscopy or even a surgical resection. So in terms of the types of lung cancer, 85% are so-called non-small cell lung cancer and 15% are small cell lung cancer, which I'm not specifically going to talk about today. In terms of non-small cell lung cancer, that's further broken down into different histological subtypes, with the most common these days being adenocarcinoma and less common types including squamous cell carcinoma as well as large cell carcinoma of the lung. There has been changes in the histological patterns of lung cancer that we've seen over time. So previously squamous cell carcinoma was the dominant cell type, but over time adenocarcinoma has actually increased to become the dominant cell type. And this is thought to relate in part to changes in smoking practices. So squamous cell carcinomas tend to be central cavitating lesions associated with smoking of pipes and unfiltered cigarettes, whereas with the introduction of filtered cigarettes we can get the tobacco more out into the periphery of the lungs, which is where the adenocarcinomas tend to occur. In terms of staging investigations that are usually done in parallel with pursuing a histological diagnosis, the CT scan is the most useful thing apart from an initial chest X-ray. It might be able to identify the site, size and extension of the lung cancer more clearly than a conventional X-ray. It's also very good for looking at the stage of the nodal disease as well as looking for distant metastatic disease. As you can see here are the obvious liver metastases. The other thing that's been extremely useful in the management of lung cancer is PET scans, and it's pretty uncommon these days for a patient with lung cancer who has the thought that they may have a potentially curable lung cancer not to have a PET scan, and there is a Medicare rebate for that. So it's been found that PET scans will detect distant metastases in about 10% of patients who otherwise appear to have resectable disease on a CT scan. Also in about a fifth to a third of patients thought to be suitable for radical radiotherapy to localise disease in the chest, the PET scan will actually upstage those patients and find more distant disease that's not otherwise appreciated. So it's helpful for limiting kind of futile therapies such as futile thoracotomy, where in the past patients were open and closed for an operation because we didn't really appreciate how advanced the cancer was. It's also increasingly being used in radiation planning because it's helpful to define what is cancer versus other abnormalities in the lung, such as atelectasis, so they can target the radiation as much as possible to the cancer and spare the normal tissue. This is an example of a CT scan where we think that the patient has disease confined to the thorax based on the CT scan, but when we do the PET scan, we find an unsuspected lower cervical node, which would obviously change the treatment approach. And in fact, it's been shown that the use of PET staging can impact survival. This is a series from the Peter Mac by Michael McManus of a series of patients treated with radical dose radiotherapy to the chest. And you can see the survival based on whether that was done in an era where the patient had a PET scan or no PET scan. So in those without the PET scan, which was the blue line here, their survival was much lower because presumably some of those patients actually had distant metastatic disease that we weren't treating, so they didn't do as well. Knowing the stage is important to determine prognosis, and unfortunately the lower the stage, the worse the survival. Overall, the 5-year survival rate for lung cancer in Victoria and in similar parts of the world is only about 15%, and this is because many patients do present with advanced disease. But the odds are much better for a patient who presents with early stage disease, such as stage 1 or 2 disease that may be suitable for surgery. Apart from the stage, there are other adverse prognostic factors that we can identify, and these include reduced performance status, higher stage disease, weight loss of more than 10% in the last 6 months, and the presence of systemic symptoms that we talked about, such as night sweats and anorexia. Also, the histology matters, with large cell being the least favourable type and adenocarcinoma being the most favourable, particularly if a targetable mutation is identified. In terms of the treatment, there are 3 major treatment modalities that we use, and these include surgery, radiotherapy and chemotherapy. And the choice of treatment depends not only on the stage of disease, but also on the fitness of the patient for therapy. For early stage disease, the first question we always ask is surgery possible? Because if you can completely resect the disease, that gives the best chance of cure. This is mostly done for stage 1 or stage 2 disease, and you can look up the staging, but generally stage 1 disease is an isolated lesion in the lung, and stage 2 is a little bit more extensive, may have some local nodal involvement, but not involving mediastinal lymph nodes. The approach is that a lobectomy is the preferred operation. A wedge resection is possible where you just take out the segment of lung, but we know that the risk of local recurrence is higher with that approach. Pneumonectomy may also sometimes be required depending on the location of the cancer, but there's a higher risk of complications, long-term issues with breathlessness with that approach, and mortality rates are not insignificant, particularly if a right-sided pneumonectomy is required. So in terms of the workup, patients need quite careful assessment of their cardiovascular fitness and respiratory reserve preoperatively, usually done with cardiopulmonary exercise testing and respiratory function testing. Following surgery, adjuvant chemotherapy may also be indicated. So for completely resected stage 2 and stage 3 disease, there's now evidence that giving cisplatin-based chemotherapy for 4 cycles can significantly improve overall survival to a similar degree to what we see in ladies with breast cancer. So moving on now to local regionally advanced disease. So this is now we're talking about non-resectable stage 2 or stage 3 disease, so generally involving mediastinal lymph nodes. The routine approach is to treat these patients with concurrent radiation and chemotherapy, and we know that this treatment can have good outcomes with median survival times out to 30 months in carefully selected patients using PET. We also sometimes use this approach in patients with earlier stage disease who thought not to be good candidates for surgery because their lung disease won't allow them to withstand significant lung resection. There are other approaches that are sometimes used, and this includes giving neoadjuvant chemotherapy and then surgery for N2 disease, but this hasn't really been proven to be necessarily superior to upfront chemoradiation. The exception to this is Pancoast tumours, like I showed you before with the Horner syndrome, where there are studies that suggest that having chemoradiation followed by surgery gives a superior outcome to using chemoradiation alone. Unfortunately, though, about 60% of patients present with advanced disease where cure is not possible, and then the treatment really depends on the patient's symptoms and preferences for treatment. And the aim of treatment is to control, certainly to prolong life if that's possible, but importantly also to minimise symptoms and improve quality of life. And early referral to palliative care for these patients has been demonstrated to be of benefit. We know that these patients are often highly symptomatic. This is data showing some supportive care screening in a series of patients from Peter Mac, with similar results seen from other centres, where the most common symptoms are fatigue, dyspnea, pain, loss of weight, and problems eating. So how about using chemotherapy? So lung cancer is one of the few cancer types where trials were actually done way back comparing chemotherapy to best supportive care, and we're actually able to demonstrate that survival is better if you have chemotherapy. So in the best supportive care alone arm in this study, the median survival is only 4 to 6 months, with about 10 to 15% of patients alive at 1 year. And that's that figure that you sometimes hear patients come and tell you that their GP said, well, I'm going to be dead in 6 months. Is probably coming from these sorts of studies. With chemotherapy, the response rates, or the ability to significantly shrink the size of the tumour, is seen in about 1/3 of cases, so it certainly doesn't work for everyone. But it can prolong survival times by a median of another 3 to 6 months, so we're now moving the survival out to around 12 months, with 40% of patients alive at 1 year. It's also been shown that you can actually improve quality of life scores with giving chemotherapy by improving symptoms. And the best results are seen with a so-called platinum doublet, so a combination of two different chemotherapy agents given to patients who are of good performance status. It has been found in studies that there's not any real benefit to giving more than 4 cycles of chemotherapy if there's no response or only stable disease achieved with treatment. In terms of the type of chemotherapy, there's a range of these platinum doublets are available, and studies such as this one demonstrate that they're all fairly equivalent in outcome. A subsequent study has shown that the best results are seen with a combination of platinum and pemetrexed, which unfortunately is not currently approved on the PBS for first-line treatment of lung cancer. So generally, unless the patient's wanting to self-fund treatment or insurance can pay for it, we're using platinum gemcitabine or platinum paclitaxel. So how could we then improve on these results? So there's been a lot of interest in maintenance chemotherapy, which involves giving additional chemotherapy after that first 4 cycles or thereabouts of the chemotherapy. And this is an important study that demonstrated the benefit of maintenance pemetrexed, where people who had initial chemotherapy and basically didn't progress, so achieved at least stable disease, were randomised to have additional pemetrexed chemotherapy once every 3 weeks or a placebo. And they actually found that overall survival was better in those that had the pemetrexed, although you can see there that the size of the benefit is relatively modest, with a median improvement of a bit under 3 months. But what they did find in this study is that the benefit really depends on the type of histology. So for squamous patients, there was not really any benefit from the maintenance pemetrexed, but the benefit was all seen in those with non-squamous disease, where here the benefit's now 5 months in terms of median overall survival. How about just being optimistic? Many of our patients are very interested in the impact of kind of stress and psychological status on survival, and although that's very important for many other reasons, it doesn't seem that just by thinking positively you can make your survival any better, as you can see in this study done by Penny Schofield. And that's an important message to be able to convey to patients, because sometimes they put incredible pressure on themselves and think that if I'm not being positive and thinking positively all the time, my cancer is going to grow. So you can actually reassure them if you're having a bad day or you're having a cry, it's not going to make any difference. How about early palliative care? This was a very influential study published out of the US now 5 years ago that really has changed the way America thinks about palliative care. We've all historically had pretty good services in Australia, but that's not been the case over there. And this was a randomised controlled trial where they compared referring patients to palliative care basically at diagnosis with metastatic non-small cell lung cancer versus when the clinician thought that it might be appropriate for the patient. And they actually showed very surprising results in that those who were referred early had both improvements in quality of life as well as mood. So in terms of quality of life, it was significantly improved in the intervention group for some of the measures there that they used, which is specifically focused around lung cancer symptoms as well as general quality of life. And also, as you can see here, there were significant improvements in the percentage of patients scoring high on depression measures, which was less than half in the intervention group at the 12-week period. But this isn't what got the study such high impact. It was actually these findings. So unexpectedly, they actually found a survival benefit from the early palliative care, which they weren't expecting to find. Certainly it wasn't a primary endpoint. But there was a clear separation of the curves with the early palliative care group having a much superior survival to the standard group. And that this was despite the fact that those in the early palliative care group were actually receiving less treatment. So they were having less use of things like chemotherapy or radiotherapy in the last month of life and more involvement with hospice care. How about second-line chemotherapy? So the effects of this are pretty modest. There's a drug called docetaxel, which again has been compared to best supportive care in the second-line setting and shown to have a survival advantage, but the degree of benefit is very modest, with the median improvement only being 6 weeks. Docetaxel is a pretty nasty drug to have. It makes everyone lose all their hair and feel pretty lousy. So it has been compared to pemetrexed in this setting, and outcomes are really equivalent. So generally, pemetrexed would be considered particularly for a patient with adenocarcinoma if they didn't have a targeted therapy option. So moving now to targeted therapies, the epidermal growth factor receptor is very important to look for in patients, particularly with adenocarcinoma of the lung, because it's something that there are targeted therapies available for. So it's a receptor that sits on the cell membrane and has an extracellular component and an intracellular component, and people have tried to target it using monoclonal antibodies from the outside as well as tyrosine kinase inhibitors which target the intracellular domain. What does it do, this receptor? Basically, when it's switched on because of a mutation within the lung cancer, within the EGFR receptor, it drives growth of the cancer by signalling down these quite complex intracellular signalling pathways to make the cell divide in an uncontrolled way. So in lung cancer, the targeting from the outside with monoclonal antibodies had very modest effect, but the molecules that have really been very successful have been the tyrosine kinase inhibitors, so small molecules that inhibit that intracellular tyrosine kinase domain. Initially, they were trialled after patients who'd had a lot of chemotherapy, and it was found that they had about a 10% response rate, but importantly, about 40% of patients had a symptomatic benefit. And if this occurred, it usually occurred quite quickly within the first month of taking the tablet and really worked similarly or better to second-line chemotherapy. Initially, when these drugs were developed, they didn't really know how to select the patients best for treatment, but they did note that there were more responses in females, Asians, those with adenocarcinoma and those with never smokers. And really now it's been identified that those who are most likely to respond have actual mutations in the EGFR receptor that we can test for on the baseline biopsy sample. This is just some nice pictures of some CT scans of a patient pre and post-treatment with gefitinib, and you can see the very dramatic reduction in the bulk of disease after only 2 months of taking a once-day tablet. They are generally very easy tolerated medications, certainly much easier to have than chemotherapy. Specific toxicities that they can cause is some degree of diarrhea, which is normally manageable with a little bit of Lomotil, or sometimes not even that's required. But also occasionally they can cause an acneiform skin rash, which is unpleasant for patients, both on the face and sometimes on the torso. We don't treat it with topical anti-acne medications. That tends to dry it out and make things worse. In fact, it's relatively easy to manage with the use of antibiotics such as minocycline or doxycycline, as well as topical steroids. It's also important that patients try not to get sunburnt. And a rare but important side effect to know about is interstitial lung disease, most commonly described in the Asian population. So if you start one of these agents and a patient suddenly gets much worse in terms of their breathing, it's important that they come in and have a CT scan to exclude this being a possibility. So after initially confirming benefit of these agents in later lines of therapies, people have tried to test them in frontline. And this is another pivotal study, the so-called IPAS study, which was a randomised controlled trial comparing gefitinib, one of the TKIs, versus carboplatin paclitaxel chemotherapy in first-line treatment of non-small cell lung cancer. This shows you the study design. And there was some degree of selection of patients in this study. They didn't at this time know that EGFR mutations were what we really needed to look for, but it was done in an Asian population, and they were particularly including never or light ex-smokers, randomised, as you can see there, to have either the tablet or the routine chemotherapy. So when they initially got the results, negative study, overall survival is no different between the two groups, pretty disappointing. But when they looked at the progression-free survival curve, they found this unusual finding in that the curves actually cross over in the middle, which you virtually never see in oncology. And this gave them a hint that there may be two different populations of patients responding differently in this study. And that, in fact, proved to be the case. So when they looked at the EGFR mutation negative group, these patients did much better with chemotherapy. But when patients had a positive for an EGFR mutation, they had significantly improved survival with the gefitinib. And so this forms the basis for how we actually manage patients in the clinic first line these days. So they're now approved on the PBS for first line treatment of EGFR mutation positive non-small cell lung cancer. There have been a number of second and even third line agents that have been developed that people can sometimes move on to if they develop resistance to the first line agent. And very interestingly, they've been able to identify certain resistance mutations in the receptor that can occur, such as this T790M resistance mutation that you can test for on a repeat biopsy. And then it's been found that some of these second line agents are effective against that resistance mutation. Also, pleasingly, some of these second-line agents really only target the EGFR in the tumour rather than the EGFR in the skin and the gut that gives the rash and the diarrhoea. So these agents have much less toxicity than the first-line inhibitors. ALK is another rare but important abnormality to identify in patients with lung cancer. So it was first identified actually in the haematology space, but subsequently was identified in patients with non-small cell lung cancer. So this one is not actually a mutation, it's actually a fusion gene resulting in a break and a translocation of EML4 and ALK, producing this fusion gene that then gets the cell to produce a chimeric protein that drives growth of the cancer. It's seen in about 4% of cases with lung cancer, which you might think, well, that's pretty rare. But because lung cancer is so common, that's actually more cases in Australia than people with Hodgkin's disease. So it's important to identify. It's more common if patients are younger, again, have a minimal or absent smoking history. And if you see a histology report that shows signet ring or mucinous cribriform histology, that may be a clue that there may be an ALK rearrangement. We can test for it by using this FISH assay. We screen using immunohistochemistry, and if the immunohistochemistry is negative, it's unlikely that this is present, but then the confirmatory test, if the immuno is positive, is to do this FISH assay, where they're specifically looking with these red and green probes for either end of the fusion gene, and if they're spaced apart rather than being together, that means that the ALK fusion gene is present. So there's also tyrosine kinase inhibitors developed against ALK, and crizotinib was the first inhibitor tested in the clinic, which actually not only inhibits ALK but also inhibits a range of other things such as c-Met and ROS, which is another important molecular abnormality we can screen for, but I'm not going to describe further today. And this was initially tested in a phase 1 study, but the early on in the study, the investigators soon worked out that it was really the ALK-positive patients that were likely to benefit. So they specifically tried to put ALK-positive patients on the phase 1 study. And you can see here the so-called waterfall plot. So this is a new type of plot that's commonly reported in oncology that looks at the maximum change in the size of the tumour. So if the tumour is increasing, you'll see it going above the line. If it's decreasing, the bar's going below the line, and each line is an individual patient. And you can see that virtually all of the patients had some degree of benefit from the crizotinib on the phase 1 study if they were ALK positive. So they found a so-called objective response rate, which is where the tumour's shrinking by more than a third of 60%, and the median progression-free survival was 9 months. It's a very well-tolerated medication, sometimes causes a bit of mild gastrointestinal disturbance and also some bradycardia, but otherwise is quite well tolerated. It does cause an unusual visual disturbance where people tend to describe seeing kind of fuzzy lines or flickering lines when their gaze shifts from dark to the light, particularly first thing in the morning. But this has not been found to be associated with any actual pathology in the eye. So patients can be reassured that this is normal and they just tend to get used to this. It doesn't stop them performing normal daily activities once they get up and get going. It's also been recently found that if you actually use this drug as first-line therapy in an ALK-positive patient, that the outcomes are much better than using chemotherapy. And because of this study that involved Ben Solomon from Australia, crizotinib is now on the PBS as of the 1st of July 2015 for first-line treatment of ALK-positive non-small cell lung cancer. So although I've shown you a couple of the abnormalities, they're the important ones that we have good targets for at the moment, but there are actually others that we can test for in the clinic that targeted treatments are starting to become available for, and that includes things like ROS that I've mentioned, as well as HER2 mutations. There is a large group, unfortunately, up here of so-called RAS mutations, which are very common, more common than EGFR, but at this point we don't have a good targeted therapy for them. And the chance of finding one of these mutations is specifically higher if you have someone who's been a never or a light smoker with adenocarcinoma. So you'd expect in about half or more of these cases that you're going to find a potentially targetable mutation. So it's really important that we don't have these patients just having an FNA or a poor diagnostic quality specimen to make diagnosis. We really need a good chunk of histology so that we can get the mutation testing done. And finally, just to touch on immunotherapy for lung cancer. This is something that's only new into the clinic within the last couple of years. So you'd know in oncology that there's been a lot of interest in immunotherapy research for a long time. Many, many studies done with very disappointing results. Up until the last several years, when it was actually identified that there these so-called checkpoints on the cells and within the tumour microenvironment that prevent the normal immune system from recognising the tumour. So in terms of how this works, in terms of normal T cell activation, what happens is the antigen presenting cell presents the antigen via the MHC, which binds to the T cell receptor on the T cell, as you can see in the top here. But you need an additional step, you need an additional signal to activate the T cell, which involves B7 on the antigen presenting cell binding to CD28 on the T cell to provide co-stimulation. But we have a built-in mechanism within the body to stop overexpression and activity of the T cells, which might damage our normal tissues. And this involves this molecule here, CTLA4. So when the body sees that this process is happening, CTLA4 starts to be upregulated, and this binds to B7, which is an inhibitory signal that tells the process to stop. So the CTLA4 acts to turn off activated T cells and damp down the immune response. And ipilimumab is an antibody treatment that's been developed against CTLA4, which is able to stop that inhibitory pathway and allow activation of the T cells that can then attack the tumour. And this has been found to be really highly exciting treatment in the treatment of melanoma, not so much in lung cancer, and unfortunately associated with a number of side effects because sometimes we can also see autoimmune toxicity. The other important mechanism that's been identified is T cell silencing by the tumour in the so-called effector phase of the immune response. And this relates to this PD-1 or programmed cell death molecule, which is another inhibitory receptor which is found on the T cell surface, as you can see down here. And PD-L1 is its primary ligand, which may be expressed by the tumour, on the tumour itself, or sometimes on tumour-infiltrating macrophages and other cells. And basically, when PD-1 binds to PD-L1, the activated T cell is switched off, and so it can't have any effect in attacking the tumour. And they have now developed inhibitors both to PD-1 and PD-L1, with their lead candidates in the clinic being pembrolizumab and nivolumab, which are PD-1 inhibitors. And it's thought that tumours with more kind of mutations or more abnormalities within them, which lead to increased numbers of neoantigens, are those that are more likely to be responsive to this type of treatment. And you can see that behind melanoma, lung cancer, both squamous and adenocarcinoma, is next in line. This was the phase 1 study using an anti-PD-1 antibody in the clinic, published in 2012. This was a group of really heavily pre-treated patients who had several lines of chemotherapy. Many of them were actually on death's door, and they were given these inhibitors. This is another type of plot that we now see in oncology, which is a so-called spider plot. So again, we're looking at the change in the target lesion from baseline and looking at the size, whether it's going up or going down, but also looking at different time points over time. And you can see here that there were several patients who had very dramatic responses to this agent, which seemed to be very durable. So the response rate was about 20 to 25% in the 2 different studies that were done. And in those that did respond, seemed to respond potentially long term. So of course we want to know, is this better than using chemotherapy? So the first studies after the phase 1 study were studies comparing the inhibitor to chemotherapy in second-line lung cancer. And this is an example of a study that's changed practice again because it was positive. Interestingly, we now often see major oncology results initially being announced as press releases before we actually see the presentation or publication. So we saw the press release in January of last year that the study was stopped early because the primary endpoint was positive. We then had FDA approval in the US within a couple of months before the first actual public presentation of the data at the big American Oncology Conference in Chicago called ASCO, with the New England publication on the same day as the oral presentation. This is the curves from that study. Remember that docetaxel, that agent that I showed you, wasn't very good as second-line treatment. It was better than best supportive care by about 6 weeks. And so this is the comparison with nivolumab, where you can see a clear improvement in median overall survival. And importantly, in immunotherapy, it's thought to be the percentage that are alive at the 1 and 2 and even 5-year mark that's the most important indicator of efficacy. So here the chance of being alive at 1 year is nearly doubled in those patients treated with the immunotherapy. So what you need to know for clinic, significant survival benefit, definitely improved response rate. The toxicity profile is different from docetaxel, and these agents certainly can cause autoimmune toxicity, including rash and other problems such as autoimmune colitis. And it's really important that you know about this stuff and how to manage it, which I think would be the topic of some of the other lectures. We still don't really know who's the best group of patients to give this treatment for. There is a thought that maybe it's those patients with PD-L1 positive tumours, so where the tumour cells are expressing PD-L1 who benefit most, but it doesn't seem to be completely black and white. The immunohistochemistry tests that have been developed are variable and not always reliable, and we know that some patients who are PD-L1 negative also can respond. So these agents are now available in the PBS for melanoma, but not yet for lung cancer, although we expect that they're not going to be far away. They are available through various access schemes from some of the companies for patients who've progressed after chemotherapy. And this is my final slide, which again came from ASCO, the big American meeting last year, just highlighting the fact that immunotherapy is really transforming cancer care in a number of different disease types, hopefully into a chronic disease. And it has been predicted that immunotherapies will likely become the treatment backbone in up to 60% of cases over the next 10 years. So that will be very exciting if that proves to be true. Okay, thank you very much.